Hello students, my name is Dr. Arulprakash, Associate Professor from the Department of Orthodontics, Vinaya Mission, Sankaracharya Dental College. Today we are going to see about cephalometrics in orthodontics. In cephalometrics we are going to see about the basic cephalometric analysis that we need to use in our daily clinical practice. So in this, what we are going to see now, we are going to see about definitions. What do you mean by the cephalostat and the types of cephalograms, uses, drawbacks and the applications in orthodontics and the landmarks. What are the landmarks? The hard tissue, soft tissue landmarks, whether it's an unilateral or bilateral, and the soft tissue analysis also. In definition, the origin of the cephalometrics is, the cephalo means it's a head and the metrics means it's an analysis. With this film we are going to do an analysis that is called cephalometric analysis. The measurement of the head width related to the specific reference point used for evaluation of the facial growth, development with including the soft tissues. So this is one of the supplementary diagnostic aid. So the X-ray was introduced in 1895 by Röntgen, and the cephalometric radiograph was introduced in orthodontics in 1931 by Holy Broadbent of USA and Herbert Hoffert of German. So this is the device which is used to take an cephalometric analysis. This is the cephalostat. This is the device which is used to hold the head in the natural position. So that is called cephalostat. This was designed by Broadbent to position the head in all the three planes of space. So there should not be any rotation in the head position. If you do any rotation, you won't get a good image. So that's what he decided to make one device to position the head in the normal position in all the three planes of space, X, Y and Z. There should not be any rotation in that space. So that is called cephalostat. So this is the ear rod, both the sides it will be there, and this is the head positioning forehead clamp. On orbit pointer will be there, they will use to place it below the orbital bone. So to hold the head in the normal position. So if you see that picture here, this one, there won't be any differences in the lower border of the mandible. Here if you see here, there is a two borders you can see, two mandibular borders you can see, two lower third molars, two upper molars and two condyles you can see, because they didn't position the patient in a proper position in the cephalostat. They didn't check that three planes of space. If you didn't check it properly, you will get an blurred image like this or double image. You can't do a proper cephalometric analysis. So this is the main thing that you have, your steps should be, and position, you have to position the patient head in a proper position, otherwise you will get two images. So the three things you should know. The cephalostat is a device which is used to hold the head in the position in the unit, and the cephalogram is a film. The two films is there. This is the older one, conventional film, and this is the digital film. And the cephalometrics is the analysis which is used to do calculations of teeth, soft tissues and the skeletal parts. This is cephalometric analysis. So this is the two films. And the types of cephalograms are, one is the lateral cephalogram and the frontal cephalogram. The frontal cephalogram we used to take for a patient with an facial asymmetry. Which side of asymmetry is there, whether it's on right side or left side asymmetry is there, that we can find out with this anterior posterior or frontal cephalogram. So what are the uses of cephalometrics is, it is used to determine the skeletal structure and the facial type of a patient. It is used to establish the relationship between the maxilla and mandible and to determine the type of growth, whether the patient is a vertical grower or horizontal grower, and to assess the dental relationship between the maxillary dentition and the mandibular dentition, and to analyze the soft tissue defects, and to establish the location of malocclusion, whether it's a skeletal or dental, and how much of dental malocclusion is there and how much of skeletal malocclusion is there. With this analysis we can make it out. And the treatment plan also can be done based on these cephalometric readings. It's also used to determine how far the treatment can be purely done by an orthodontic correction, or you can go for a knee surgical correction, or you can do it for combination of both. And so for pre and post treatment analysis as a valid record and used in the growth prediction and can be easily stored and can be transported. Coming to the drawbacks, the radiation, one thing, and the second thing is structure being imaged as an 3D, whereas the radiographic image is an 2D image. There is a chance for errors like distortion of an image, magnification, and in the film processing there might be some errors is there. Nowadays with the recent advance in digital cephalometrics, this film processing errors won't be there, and some referral landmarks and planes do not agree with the anatomical landmarks. So the landmarks, if you come to see the landmarks, there are two types. One is the hard tissue. The hard tissue landmark is nothing but what are the landmarks you are going to take it in a bone, that is called hard tissue landmarks. And the soft tissue landmarks, we are marking it on a soft tissues, that is called soft tissue landmarks. So you can see one is the Ceph and one is the drawing image. In this you can see the lot of points are there. The point like N, this is the point which is marked in the outer surface is the soft tissue. So here this is called N. The same point which is marked on the bony prominence is called skeletal N. There is a nasion, the nasal bone and the frontal bone. No? The joining of nasal bone and frontal bone, that point is called as a nasion. And this is the S point, scella. This we will see in detail in the upcoming slides. But in the mandible, if you see the point B, pogonion and gnathion, menton, these many points you will get it in the mandible, symphysis area. This is the nasion. This is the most anterior point midway between the frontal and the nasal bone of frontonasal suture. The orbital is the lowest point on the inferior bony region of the orbit, this one. Porion, the bony point on the upper margin of the external auditory meatus, the ear. No, here you can, some of the doctors they used to take a machine porion. Machine porion is nothing but in cephalostat we had seen that ear rod, no, to hold the head in the position. The rod image will be there on the cephalogram. Some of them they used to take that machine porion, that point. That is called machine porion. They used to call it as a machine porion. So here is the anatomical porion. The sella is the point representing the midpoint of the pituitary fossa or sella turcica, midpoint. It is a constructed point in the mid-sagittal plane. This is a constructed point. Either just like that you can just place it on the center, or you can close this circle, the sella, and the center of the circle is called as a sella. You can mark like that, or just like that you can mark it on the center. So next one is the point A. It is the deepest point in the midline between the anterior nasal spine and the alveolar crest between the two central incisors. This is called, the other name of the point A is called as the subspinal. The point A represents the maxilla. The next one is the basion point. This is the basion point. It is the median point of the anterior margin of the foramen magnum. That foramen magnum is down, it will be there. That anterior point is called as the basion. Anterior nasal spine. It is the anterior tip of the sharp bony process of the maxilla in the midline of the lower margin of the anterior nasal spine. Gonion is the construction point at the junction of the ramal plane and the mandibular plane. So here just like that you can mark this gonion. Otherwise what you have to do, you have to draw one line on the posterior border of the ramus and one point on the lower border of the mandible. So you have to bisect it, and that point you have on the bony prominent, you can mark that point as an gonion. And the point B is the deepest point in the midline between the alveolar crest of the mandible and the mental process. This is the point B. It also called as the supramental. This point B represents the mandible. Point A represents maxilla and point B represents the mandible. Pogonion, it is the most anterior point of the bony chin in the median plane. This is called pogonion. Gnathion, it is the most anterior and inferior point on the symphysis of the chin. It is the construction by intersection of the line drawn perpendicular to the line connecting the menton and the pogonion. So like this, you have to draw one line here and one line here, and you have to construct like this. This is called gnathion. And the menton is the most inferior point on the mandibular symphysis, the downward point. So if you see in the mandible, you will get point B, pogonion, gnathion and menton. That 4 points you will get it. This is the conventional cephalogram. Before starting the tracing, always it's better to do with an hand tracing. Whether you will get a digital film or conventional film, it's always better to do an hand tracing. Nowadays in recent advance, you can lot of cephalometric analysis are there, or softwares are there, DigiCeph, NanoCeph, like that lot of cephalometrics tracing softwares are there. Even though it's better to do a tracing manually, it's like taking a history or talking to a patient for longer time. By that you can understand the problem of skeletal and dental malocclusions if you do it by hand tracing. So before starting the tracing, you should do a marking, reference marking like that. That plus marking is there, no, like this. 2 marking on the inside the skull and 1 outside the skull. Here you will do it. And next thing, you have to start tracing the soft tissue like this. And the second thing, you have to start tracing the hard tissues. So this is the nasal bone, this is the maxillary palatal bone and the maxillary anterior, mandibular anterior, posteriors. Here while drawing the molars, you have to correlate the molar with your model or patient photograph, whether it's in class 1, you have to draw it like in class 1. Here first what you do, you have to mark both the medial and the distal margin of the molar and you have to complete drawing it. And stencils also available there for tracing the cephalometrics for teeth. And this is the mandible with the condyle, you have to draw it. This is the porion. Already I had said that 2 porions will be there. One is the machine porion. This, can you see the one small round here? This is the machine porion, that ear clamp. Anatomical porion, this is the point where you have to draw the anatomical porion. This is the sella. So sella turcica. If you want to mark an sella, just like that, you complete the circle and you just place a center of that point, that is called S. This is the way how to draw the ceph. Can you see one more marking in the down, that you have to draw it outside the skull. So why this reference marking should be there means, sometimes that ceph sheet, tracing sheet, we will place it over the film, just like that we will staple it or we will tape it with then cellophane tape. Sometimes there is a chance for the movement of the tracing paper. So each and every time we have to make sure that all the 3 reference lines are correlating with the line what we have drawn on the cephalogram. So if there is any deviation, then we have to stop it and we have to adjust the tracing paper, then you have to start marking the landmarks. So here I think here you can see the 2 drawings of the vertebra. The left side one, you can see that marking is same. Both the marking in the film and the tracing paper is same. If you see in the right side, there is a movement. So if you didn't notice this, if you draw and if you mark the points, all the anatomical points, and if you take in value, you will get a misreading. So that calculation you won't get the proper diagnostics. Okay. So this is the most important while if you are doing a hand tracing. So coming to analysis, we are going to see about the 3 analysis. So these are the basic analysis that we should know, and we can do it for our patient for our day-to-day practice. So the first one is the Steiner's analysis. The Steiner's analysis was developed by Steiners in the year 1950. Here he had divided the analysis into 3 parameters. One is the skeletal, to find out whether any malocclusion is related to the skeletal problem. And the second one is the dental. Is there any malocclusion in the dental region? And the third one is the soft tissue region. So according to Steiners, we had seen lot of landmarks. So Steiners had taken some landmarks, that is the nasion. The nasion is the nasal bone, the junction of frontal bone and the nasal bone. This is the S point is called as the sella, and for nasion he had given the name as N. And anterior nasal spine, ANS. Posterior nasal spine is the PNS. Point A represents the maxilla and point B represents the mandible, and gnathion, gonion. So these are the points he has taken for his analysis. So the planes which is used by Steiners are SN plane. SN is nothing but sella nasion. The line which is connecting the sella point and the nasion is called as an SN plane. According to him, this is the reference plane because this is in the mid-sagittal plane. So there won't be any change or deviation in this plane when you rotate the head in any plane of space. So and the second one is the palatal plane. This is the plane which is joining anterior nasal spine and the posterior nasal spine. The third one is the occlusal plane which is connecting the occlusion, the maxillary and mandibular occlusion. You have to trace it. And the last one is the gonion and gnathion, the point connecting gonion and gnathion. This is called as the mandibular plane. So the SN plane, the Steiner elected to use this anterior cranial base, the sella to nasion line for reference, to relate the jaw to the cranial base. So the advantage, they are moved only in minimal amount whenever the head deviates from the true profile position. This remains true even if the head is rotated in the cephalostat. So first in skeletal analysis, we are going to see about how the maxilla is. We are going to compare the maxilla to the cranial base. So the line here used is SN line, and he has taken from N, he had drawn one line to the maxilla. So this shows how the maxilla is, whether the maxilla is prognathic or retrognathic. So just imagine if your maxilla is prognathic somewhere here, so you will get an value like this, increased value. The same time the maxilla is retrognathic, you will get an decreased value. So this we will see in upcoming slides. To determine the anterior posterior position of the upper arch. So whether the maxilla is more forwardly placed or less forwardly placed. Here the mean value is 82 plus or minus 2 degrees. 82 plus or minus 2 means 80 to 82, it is normal. If it is more than 80 to 84, it is normal. If it is more than 84, it shows the prognathic maxilla. The maxilla is more forwardly placed. If it is less, it shows the retrognathic maxilla. The prognathic maxilla you can see in skeletal class 2 patients. In retrognathic maxilla you can see in skeletal class 3 patients. So this is the picture which shows normal maxilla, protrusive and retrusive. Here the value is 82. So this S, N and A. This is 82. So this shows the maxilla is normal. Here if you see, it is an increased value. So the maxilla is more forwardly placed. So this is called prognathic maxilla. And here the maxilla is behind the mandible. You can see here mandibular anterior is more forward ahead of maxilla. So here this shows that the maxilla is retrognathic. The same will apply for mandible also, that we will see in an upcoming slides. So here we had finished the maxilla, come to the mandible. The point B represents the mandible. Point A represents maxilla and point B represents the mandible. The same line only, the reference line for Stenosis is SN line. So the line joining sella and nasion. Here we have to draw one more line from N to point B. So this one. So here the mean value is 80 plus or minus 2. It means 78 to 82. So if the angular reading is, if it is more than 82, it shows prognathic mandible. If it is less than 78, it shows it is retrognathic mandible. So here we can see the first one is an 80, the mandible. We are going to see here mandible. So the first one, the reading is an 80, so it shows normal mandible. The next one is then retrusive mandible. The mandible is more backwardly placed. So it is retrusive mandible. This shows that mandible is placed more posteriorly. You can see this in skeletal class 2 patient due to mandibular retrognathism. So the next one is then protrusive mandible. You can see it's an 86. So S, N and B line. Here the lower anterior is more forwardly placed than the maxilla. So this is 86 degree. This you can see it in a skeletal class 3 patients. So based on this SNA and SNB angle, we will come to a conclusion whether the maxilla is at fault or mandible is at fault. Based on that growth of that patient, we will decide the treatment plan, whether the patient is in growing or non-growing. If a patient is in growing, so we can go for a growth modification appliances. If the patient is a non-grower, so we have to assess the growth, how much is left out or all the growth got completed. Then we have to plan for a surgical correction, orthognathic surgery. So this is one analysis which shows the maxillary and the mandibular defects. So the difference between A and B angle. The A and B angle is nothing but the point which connecting point A, N and B. Once you finish SNA and SNB, you will get this A and B angle. This provides the information on relative position of the jaw to each other. In first two analysis, we compare maxilla to the skeletal base and mandible to the skeletal base. Here we are comparing both maxilla and mandible to each other. How the maxilla is placed compared to mandible and mandible is placed compared to maxilla. The mean difference should be 2 degrees. If it is more than 2 degrees, it shows that there is a skeletal class 2 tendency, whether it might be due to an maxillary prognathism or mandibular retrognathism. In some cases you can see only the maxilla is prognathic, normal mandible. In some cases you can see normal maxilla and retrognathic mandible. In some cases you can see both prognathic maxilla and retrognathic mandible. And the same way class 3 tendency, you will get an less than 0 or less than 2 degrees or 0. So this shows that it's a skeletal class 3 patient due to retrognathic maxilla or prognathic mandible. The same way normal maxilla or prognathic mandible or combination of both. We had seen in a sagittal plane, anterior posteriorly we had seen. Now we are going to see about the vertical plane. We are comparing now here in this upcoming slides. We will see how the palatal vertically, how the palate is there, it means the maxilla is there, how the occlusal plane is there, and how the mandibular plane is there. These three things we are going to see in an upcoming slides. This is the palatal plane, the plane connecting PNS and the ANS. So the mean reading for normal palatal plane should be 8 degrees to the SN plane. This palatal plane we have to transfer to the SN plane. This I will show in the next slides how to transfer this by hand tracing. So like this you will get it. So this reading is called, this should be 8 degrees. If it is more than 10 degrees, it indicates a steep maxillary plane. You just imagine if your maxilla is somewhere like this, so you will get an 8 degrees. So see how your maxilla will be. Gummy smiles will be there, more incisal visibility, upper incisal visibility is there. So in such cases the palatal plane will be more downward, and if it is less than 6 it shows flat palatal plane. If it is less than 6 it shows more palatal plane. In some open bite cases you can see like this, the maxillary palate is or the maxilla is upward. In that cases you will get less than 6 degrees. So this is the way how to transfer the palatal plane to the SN plane. So going back to our school days, that if you want to transfer one line exactly to the other line and to find out how much of angle is there between the two lines, this is the way we used to transfer. We'll put one base scale in the base line and two set squares, one on the left side, one on the right side. So there should not be any gap between these 3 point scale and the set squares, and you have to hold the left side set square, this one, and the scale with your left hand index finger and your thumb finger, and you have to move this set square upward. So like this, see this is stable, and this we had moved upward. So we are going to transfer this palatal plane exactly to the SN plane. See, now we have taken this to there. So you have to make sure that there should not be any gap here, and there should not be any gap here. If it is there, you won't get the exact plane there. And you just make sure this reference, it should be correlated with the cephalogram, and you have to draw it, and you have to take the value, and you have to measure it, and you have to take how much of value is there. So the same palatal plane we have transferred this. So this is the way to transfer the plane, the same palatal plane, the occlusal plane, and the mandibular plane, these planes like this, to the SN plane, and you have to take the values, and you have to find out what are the drawbacks are there. So the same way occlusal plane we have to transfer from here to the SN plane, and you have to find out the mean reading is 14 plus or minus 5 degrees. If it is more than 90 degrees, it is a steep occlusal plane. If it is less than 9 degrees, it shows as flat plane. In the same way mandibular plane, this shows how the growth of the mandible is, that whether the patient is in vertical grower or horizontal grower, like that. So it is a line drawn between the gonion and the gnathion. So we are going to relate this to the SN plane. The same way how we transfer the palatal plane, the same way you have to transfer it, and we will take in values. The mean reading is 32 plus or minus 5 degrees. It means if it is less than 27 degrees, it shows an horizontal growth pattern. If it is more than 37 degrees, it shows it's an vertical grower. So based on that, we will plan for a treatment. So we had finished the skeletal analysis. Now we had come to the dental analysis. In dental analysis, we are going to see about the maxillary incisor position, the mandibular incisor position, and inter-incisor position. We are going to compare both the maxillary anterior and the mandibular incisors, and the lower incisor to the chin position. These 4 things we are going to see in the dental analysis of the Steener's analysis. So the maxillary position, that here the teeth are related to the NA line. The line we joining point N and A is called as the NA line. And the next line we are going to draw along the long axis of the central incisor. So this angle we have to measure it. The normal reading is 22 degrees. Here we will see the 2 things. One is an angular measurement and one is an linear measurement. This between these 2 lines, how many millimeters are there? That also we will take. So what is the need for 2 measurements? Here you can see these 2 pictures. One is on the left and one is on the right. see here in the left side, all the 3 teeth are in the same 22 degrees. Point A, this teeth is in 22 degree, the B is in 22 degrees and C is in 22 degrees. And see this position, the A is in -2 to the NA line, and the next one is the 4, and the next one is in 8. So here it shows that it is in the normal angulation, but it is placed -2 degrees behind to the NA line. You can see this in class 3 cases, reverse overjet. And this C1, it is 8 millimeters away from the NA line. It shows that it is more forwardly placed or positioned here. It is 8 millimeters away from the NA line, but the angulation is 22 degrees. Here you no need to do any root corrections, just you can take the tooth back with your appliances. In the same way, if you come to the right side, it is the difference in angle. This is 22 degrees, this is 3 and this is 40. But see here the tip, it is in 4 millimeter only. Maxillary anterior is exactly 4 millimeter to the NA line, but see the angulation of the tooth. See the B1 is the right one, and the A1, you can see this in some class 3 cases, compensated class 3 cases, the maxillary and incisor tip will be in the normal relationship to the mandibular incisor relation dentally by proclining the teeth by itself 40 to 40 degrees. In some class 2 division 2 cases, you can see retrocline upper incisors. So in that you will get an 33 degrees. Here you need some torque expression like this. So this root should go back and the teeth should be in the occlusally, it should be in the crown, should be in the same position like this. Based on this, we will come to know dentally what are the problems there for the incisors. According to that, we will plan the treatment mechanics and the type of tooth movement we will plan. Either you want to do a bodily movement or tipping, either the tipping is in controlled or uncontrolled tipping. The same way, mandibular incisor, we will see we are correlate to the NB line, the line which is joining nasion and the point B. The point B represents the mandible, and the same line we have to draw one more line through the long axis of the lower central incisor. Here the mean reading should be 25 degrees to NA line to the long axis of the lower central incisor, and the distance should be 4 millimeters, same what we had seen in the maxillary anteriors. So this shows the position of lower anterior, how forwardly placed or how backwardly placed. And interincisal angle, now we had correlate the maxillary incisor to the maxillary NA line and mandibular incisor to an NB line. Now we are correlating maxillary incisor and the mandibular incisor. The line should drawn along the long axis of the maxillary incisor and the mandibular incisor, and we have to take the interincisor angle should be 130 degrees. Just imagine in these cases, if your incisor is more proclined, you will get an less angle. If your incisor is more upright, you will get more value. So with this also we will come to know whether the teeth is more proclined or more retroclined. The next one is a soft tissue. According to Steeners, the S line passes through the middle of the S formed by the lower border of the nose to the contour of the chin. So the lip beyond the S line or shows that it's a protrusive upper lip or retrusive lower lip. So this is the line that we have to mark one line on the reverse S of the nose. So this is the reverse S of the nose. This is the midpoint, you have to mark it, and to the chin you have to connect it, and you have to see whether the upper lip or lower lip is more protrusive or retrusive or balanced. The next one is then width appraisal. Next analysis is width appraisal. This was proposed to identify the difference in the maxilla and the mandible. This analysis was used in which the A and B reading does not accurately reflect the extent of anterior posterior jaw relationship. So to find out how much of jaw dysplasia is there, so here they had compared both the maxilla and mandible to each other. In Steeners, they had compared maxilla to the cranial base and mandible to the cranial base. So in this analysis, they will compare both the maxilla and mandible. Comparing maxilla to the mandible, how much of dysplasia is there between each other. This emphasizes an awareness of the relationship of the jaw to each other and to the cranial base. The width appraisal is a linear measurement, it is not an analysis by itself. This is by dropping a perpendicular line from point A and point B onto the occlusal plane to form an points AO and BO respectively. The distance between the AO and the BO point is noted to interfere the relationship between the jaws. So here the reference plane is the occlusal plane here, and we have to draw one perpendicular line to the occlusal plane connecting point A. This you have to use whether set scale, that what we had seen, no. With this we have to mark this, and this point is an AO point, and from point B to the occlusal plane this is called as an BO point. These 2 points. This difference we have to make whether the AO is ahead or BO is ahead. So for if you see in a male patient, the BO will be ahead of AO by 1 millimeter. This is the normal value. For female, the BO coincides with an AO. If you see, if AO is ahead of BO, this indicates that's a skeletal class 2 pattern, and if BO is ahead of AO, it shows an class C skeletal pattern. You just imagine if AO is ahead, so it shows skeletal class 2. Either it might be due to prognathic maxilla or retrognathic mandible. In the same way, if BO is ahead and AO is behind, it shows skeletal class 3 due to prognathic mandible or retrognathic maxilla. So here the disadvantage of width appraisal is the occlusal plane cannot be identified properly in all the cases, because if in cephalogram, if the patient's head is positioned properly without any deviation from 3 planes of space, you will get an good occlusal indentations. With that you can mark exactly the occlusal plane. If it is not so, then it is very difficult for you to mark the occlusal plane, and it is very difficult to take an readings. So sometimes the occlusal plane might be at fault, so that will give an faulty reading. So the next one is a Tweets analysis. It was developed as an aid to treatment planning and for anchorage preparation and to determine the prognosis of the orthodontic cases. The analysis is primarily based on the deflection of the mandible as measured by the Frankfurt mandibular plane angle and posterior of the lower incisors. This determines the final position of the lower incisor, and it should occupy at the end of the treatment. Then depending upon the space required, the extraction can be planned. This was designed by Tweed. According to Tweed, the lower anterior might be the reason for most of the malocclusions, or the position of the lower anterior will decide the prognosis of the treatment or the longevity of the treatment. So according to him, he had formed one triangle that is called a Tweed's triangle with the 3 planes, that is the Frankfurt horizontal plane, the mandibular plane, and the next one is the long axis of the lower incisors. So this is the line making the triangle. This is the Frankfurt horizontal plane, this is the FH plane, Frankfurt horizontal plane. The line which is joining point is porion and the orbital, one. And the second thing, the line joining the lower border of the mandible, and the one and another line, the line along the long axis of the lower incisor, where these 3 lines joins will make a triangle. So this is called Frankfurt mandibular plane angle, the line joining Frankfurt plane and the mandibular plane. This is called the Frankfurt mandibular angle, and this one is then the line joining the long axis of the tooth and the lower border of the mandible. This is called incisor mandibular plane angle, incisor mandibular plane angle. And the third one is the Frankfurt mandibular incisal angle, the Frankfurt line with an incisal long axis of the incisal line is called as an Frankfurt mandibular incisal angle. So here the mean value is FMA, it should be 25 degrees, and IMPA should be 90 degrees, and FMIA should be 65 degrees. So here if this increases, it shows the patient is an vertical grower. If it decreases, the patient is an horizontal grower. Here IMPA, this shows that the position of the lower incisor to the mandible. So you just imagine if it is less than 90, so your incisor will be like this, less than 90 means. If it is more than 90, your incisor will be like this. It shows more proclined, this shows more retroclined. So FMA from 28 to 35 will give an fair prognosis in the treatment, and at 35 degrees the majority of cases require extractions. FMA above 35 degree will give an bad prognosis, and the FMIA angle to be maintained at 65 to 70 degrees. This will give a good position of the mandibular incisor. So the ideal position of the lower incisor, which helps in the stability of the result achieved, thereby indicating the good prognosis. And the next analysis is an Downs analysis. This was given by Downs in the year 1948. Here the landmarks which is used by Downs are Nasion, Sella, Porion, point A, point B, Gnathion, Pogonion, Orbital, Bolton's point. This is the highest point on the concavity between the occipital condyle. So with these points, he had done this analysis. So according to Downs, the Frankfurt horizontal plane is the reference plane. In Steiners we had seen this S and N, but according to Downs, he had taken FH plane, the line joining the Porion and the orbital, this point. This is taken as a reference point. And other planes he used is the facial plane. The line joining N and the Pogonion is the facial plane, the mandibular plane and the occlusal plane. Here he had divided into two parameters. One is a skeletal parameter and another one is the dental parameter. In skeletal parameter, he will see in the angle of the face and convexity and how the AB plane is, and mandibular plane angle how it is, and how the growth of the mandible is, how the growth is. It's called y-axis, is called, otherwise called as growth axis. In dental, he had seen how the occlusal plane is cont, how much of cont is there in the occlusal plane, and what is the difference between the incisal angle, interincisal angle, and how it is the incisor to the occlusal plane, how the upper and lower incisor to the occlusal plane, and incisor to the mandibular plane, and protrusion of the chin. These things he had taken in the dental parameters. The facial angle, this is the inferior inside angle in which the facial line intersects the Frankfurt line. This is the inferior inside angle. So Nasion to Pogonion, we have to draw it and we have to find out how much is the value. The mean reading is 87.8 degrees with the standard deviation of 3.6 degrees. So this shows how your mandible is, whether the mandible is forwardly placed or normal or retrocline. The convexity, the angle of convexity is formed by an intersection of line N to point A and point A to Pogonion. This you have to take. This will give an convexity, whether the face is an convex or more concave, like that. The angle measures the degree of maxillary basal arch at its anterior limit, that is the point A, related to the total facial profile. This angle measures the convexity or concavity of the skeletal profile of a patient. The range extends from a minimal of minus 8.5 degrees to a maximum of 10 degrees. This shows whether the patient is an concave or convex. The concave profile you can see in a class 3 patient, and convex profile you can see in a skeletal class 2 patients. The next one is an AB plane. So you have to join point A, point B, and you have to correlate with an N2 POG plane. The AB plane is measures of an relationship of the anterior limit of the apical base to each other related to the facial plane. So if it shows increased, it shows whether the mandible is retrognathic or maxilla is prognathic. If it is less, this shows the maxilla is retrognathic or mandible is prognathic. The next one is the mandibular plane. The mandibular plane according to Downs is the tangent to the gonion to the lowermost point of the symphysis. The mandibular plane angle is established by the relating mandibular plane to the Frankfurt plane. This is the Frankfurt plane. Here we have to correlate to the FH plane. The reading ranges from 17 to maximum of 28 degrees. This shows it's an average. If it is beyond that, it shows the vertical grower. If it is less than that, it's an horizontal grower. The y-axis is the line joining Gnathion to Sella, and the line intersects the Frankfurt horizontal plane. This inner angle we have to take it, this one. This is called as an y-axis or the growth axis. This y-axis indicates or represents the degree of downward or rearward or forward position of the chin in related to the upper face. So just imagine if this angle is increased, this shows the backward or rearward rotation of the mandible. If it is less, this shows forward and upward rotation of the or position of the mandible. The cont of the occlusal plane. Downs originally defined the occlusal plane as the line bisecting the overlapping cusps of the first molar and the incisal overbite The cont of the occlusal plane is a measure of the slope of the occlusal plane to the Frankfurt horizontal plane. The minimal angular measurement is 1.5 degrees and the maximum of plus 14 degrees. If it is increased, it shows steep. If it is less, it shows flat occlusal plane. Interincisal plane, here as we had seen in the Steiners, same interincisal plane we have to take by drawing the long axis of the lower incisor and the upper incisor. If it is increased, it shows it is upright, both the teeth are upright, that you can see it in class 2 division 2 or class 3 cases. If it is less, it shows that more procline. The average is 130 degrees. Then we are comparing the incisor to the occlusal plane, both the upper and the lower incisors. Here we will draw the long axis of the upper incisor to the occlusal plane and long axis of the lower incisor to the occlusal plane. Here in Downs analysis, we will consider only the lower incisor to the occlusal plane. The inferior inside angle is read as an positive or negative deviation from the right angle. This shows that the position of the lower incisor, whether it is, if it is less, it shows that more procline, if it is more, it shows then more upright. And we are comparing the lower incisor to the mandibular plane. In the previous slide we had compared the lower incisor to the occlusal plane. Here we are comparing the lower incisor to a mandibular plane. The mean angular radian is minus 8.5 degrees, the minimal and plus 7 degrees, and the mean reading should be 1.4 degrees. If it is more, it shows then more procline lower incisor. If it is less, it shows then retrocline lower incisors. And by drawing a line to point A to the pogonion, we will see the position of the upper incisor. The protrusion of the maxillary incisor is measured as the distance between the incisal edge of the maxillary central incisor to the APOG line. The minimal reading is minus 1 and to the maximum of plus 5 millimeters, and the mean difference should be plus 2.7 millimeters. This shows that the position of the maxillary incisors to the APOG line, whether it is a position more forward or backward. And due to the recent advances in the field of dentistry, the digital cephalogram has came and plays a major role. It is one of the time saving tool. With this digital ceph, we can do an analysis directly in the software, and that will give you the readings. In that software, we will get an text box like all the analysis names will be there, like Steiners, Tweeds, Downs, Ricketts. Totally more than 30 cephalometric analyses are there. So these are the basic analysis that we had seen today. So in that digital software, you will get a lot of analysis. What analysis you want, you can choose it. In that analysis, the final result, you will get the analysis according to that. If you want a Steiners analysis, if you select a Downs, if you select the Tweed, if you select the Ricketts or Cox analysis, and you mark the landmarks, all the landmarks, and if you correct the if you find out all the landmarks are right, and if you click give a result, you will get a result for all the analysis within a fraction of a second. But if you trace by hand, you will know much about the position of the tooth or the cont of the occlusal plane or the palatal plane, like that. But if you want an do a digital analysis also, you can do it. So the next one is a superimposition. Superimposition is nothing but the X-ray which is taken in a 2 period of time. One, with that superimposition, you can find out how the growth changes are there. If you imagine that you had taken an X-ray of one patient at the age of 11 or 12 years, and the same patient is coming at the age of 16, 17 or 18 years. If you stored or if you preserved that previous X-ray, the patient had come for consultation at the age of 11, they didn't came back, and if they coming at an age of 13, 14 years, if you ask to take one more X-ray, and the patient had bring it with these reference lines like SN line, and you just imagine, if you just trace it and if you see, and you can find out how much of growth is there have taken place, is there any dental correction had taken place, or growth, you can predict the growth, either the patient had changed the growth pattern from horizontal to vertical or vertical to horizontal, like that, or natural tooth positioning changes, that you can see it. One. The second thing, this is mostly used to see the pre-treatment and post-treatment changes. Which is marked in the pink is the pre-treatment, and which is marked in the black is an post-treatment. If you are doing a case of all four extraction, and if you are take back the tooth posteriorly, retract the tooth, and you finish all the occlusal settlings and you finish the case, you have debonded, or before debonding you have taken one more x-rays and you can draw both the x-rays, and you have to take the traced films separately and you have to connect both the films on the SN line. Lot of superimposition analysis also there. The one basic is superimposing both the pre-treatment, post-treatment tracings in the SN line, and here you can see how much of changes or how much of retraction had taken place in the mandible or maxilla, or related to this how much of soft tissue changes had occurred. These are the things we can make it out with the cephalometric superimpositions. Coming to the errors, some radiographic projections errors might be there with the magnification or distortion. Errors, measuring errors we can do if you're doing a hand tracing or digital tracing. If you didn't mark the landmark properly, you will get an measurement errors, and based on the quality of the X-ray or radiograph you are not able to find out some landmarks, and if you are not able to find out some landmarks, what you do, you will just mark the point close to that landmark. That will give an faulty result. Coming to a conclusion, if you see, as I previously said, more than 30-35 analyses are there. Each analysis has an specific uses. If you see the steyness, he will give an sagittal plane and the vertical plane. If you see according to tweets, you can plan the anchorage or you can plan the position of the lower incisors like that. If you see widths, comparing the maxilla to the mandible with an occlusal plane. So like this, each and analysis have an specific role. So if you read all the analysis, you will come to know for your case, specifically if you want to know about something to find out whether the problem is in the vertical position of the incisors or vertical position of the molars, or whether the molar had moved forward or backward. Like this, each and analysis has the specific landmark identifications. So if you are interested, you can read all the analysis and you can make it out specific readings separately, and you can put it as one analysis. It's called an composite analysis. For your taste, you can choose your landmarks or parameters, and you can come to an conclusion by doing that analysis. With this cephalometrics, you will come to this will give a clear idea about your patient, whether the patient is a skeletal malocclusion patient or a dental malocclusion patient, whether you have to go for only the orthodontic correction, or you can go for an surgical correction, or the patient is a grower with an CVM, cervical vertebra maturity indicator. You can come to a conclusion whether the patient is growing or non-growing. Patient is growing, you can go for any growth modification appliances. If growth got completed, you can go for a surgical correction. With this also, you can correlate all the analysis and you can discuss with your patients. With the recent advances in the digital dentistry, you can take and save, you can put in photographs, and you can overlap the photographs with the patient X-rays, and you can do all the changes, both the soft tissue changes, and you can show to your patient that this is the post-operative picture of yours that you will look like after the treatment. So with this, you can motivate your patient and you can start your treatment plan. So thank you students for watching the class.